Hi, everybody. Welcome to today's webinar. As we are waiting for more people to dial in, I appreciate your patience. We see attendees coming in now, so we'd like to wait just another minute or two before we actually kick off. So thank you so much. Thanks again for your patience. We're still seeing more folks log on to the webinar. We're going to give it just about one more minute, and then we will begin today's webinar. So thank you so much. Okay. Well, let's get started. I appreciate everybody's patience as more folks were able to log on. My name is Joe Sasson. I'm the EVP of the Ventures Division here at MedAxiom. Thrilled to bring you this webinar today, Cardiology Care Pathway Series that we're doing. And today's specific webinar is about maximizing the impact of cardiac CT across clinical and operational workflows. There's a lot here for us today. We're going to start out with Dr. Wesley O'Neill from Cone Health. Dr. O'Neill is going to cover a whole lot of the when and why about CCTA and how it affects revascularization decisions, plaque analysis, and really what's needed to run an effective CCTA program and achieve program growth if you already have a program in place. After that, we're going to hear from Dr. Yater Sandoval, who's with Minneapolis Heart Institute, also known as Abbott Northwestern Hospital and Allina Health, up in Minneapolis, Minnesota. He's going to be talking a lot more about CCTA guided PCI and pre-procedure planning. And then we're also going to be talking about how you integrate that CCTA data into a case live. And what does it take to make all of this a reality? So we're so thrilled to be able to bring you both of these perspectives today. Again, very grateful to GE Healthcare for helping us to bring this content to you and for sponsoring this webinar. With that, I'd like to talk a little bit more about how we navigate today's webinar. You will see in front of you two options at the bottom of your screen. What you'll see is chat. Now, in that chat, you won't be able to chat back and forth with the presenters or with peers on the webinar. That is where you will frequently see today's slides posted. So you'll be able to download those from the chat. As more people join, we will probably repost multiple times into that chat throughout the webinar. Then you'll also see a Q&A button. And that Q&A button is where you can ask questions of the presenters or of the hosts of the webinar so that we're able to help you if you have any technical challenges or anything else where you would like to communicate with the staff of the webinar. Please send that through the Q&A button on the bottom right. Okay, next slide. Okay. With that, I would like to turn it over to get us started today to Dr. Wesley O'Neill. He's the Director of Cardiac CT and Nuclear Cardiology at Cone Health Heart and Vascular Center in North Carolina. Dr. O'Neill, thanks so much for joining us and for being able to share your expertise with us today. I'm going to turn it over to you.
All right. Thanks so much, Joe, and thanks to MedAxiom and GE for having me to talk about cardiac CT in today's practice. So what I'll focus on is the importance of cardiac CT in contemporary clinical practice, kind of the nuts and bolts of a successful cardiac CT program, what it takes to grow. You may already have a practice, you may be trying to scale up. I'll kind of talk about, what we've had success with at Cone Health and how we've kind of scaled our program. And I do want to focus a little on the technology piece because our institution does believe this is important about how certain technologies can really help you increase your throughput and be much more efficient with your CTA program, or if you're thinking about scaling up what you currently have. So why CCTA? Why is cardiology seeing this shift in practice? Well, in 2021, the chest pain guidelines really shifted away from stress testing as the primary recommendation for evaluating patients with stable chest pain symptoms. This guideline document gave coronary CTA a class of recommendation 1, level of evidence A, to evaluate patients with stable chest pain symptoms. And this really was because of the shift in what we can see with CCTA. We can actually see things early disease, we can see late stage of disease. And I'll talk about how it helps guide treatment decisions as well. But this is why the guidelines and practice have really shifted. When you use coronary CTA, most of the patients we do see with chest pain symptoms may not have obstructive disease, but they may have what's shown here in the blue column, or the cases in blue, non-obstructive disease. These are patients who need to be on aspirin, statin therapy. They need to have their blood pressure well controlled to prevent future heart disease events. I think the nice part about CCTA is we're also able to deal with the here and now. In the red, you see who has obstructive disease or potentially obstructive disease and who can benefit from PCI and revascularization right now. So just looking at CCTA, you're able to get a lot of information about what to do with patients, even if they don't have significant coronary disease. I like to show this just about what stress testing does, and stress testing indirectly looks at the arteries. The cases shown before directly look at the arteries. We know what we're dealing with. We know what the patient needs to have right now, and we know what they need to do to prevent future heart disease episodes. When you do nuclear stress testing, as shown here, you really see if a patient has obstructive disease, but you may miss someone who has early disease or early plaque buildup, so you're not able to get them on appropriate preventive therapies. I think that's why guidelines really shifted to CCTA as a primary modality to evaluate these patients. This is just how we use it as well. We get lesions in the moderate range or even mild range. These are just 2 case examples showing FFRCT. And what FFRCT is, it's fractional flow reserve by CT. We're actually able to take the data sets or the CT data and determine what the flow is across these lesions. These are 2 patients, patient A and B, both have 70% lesions here. If you look across the top, patient A has a negative FFRCT value at 0.86, and when they went to the cath lab, had a FFR value invasively of 0.87. This is someone who can be managed medically, and it was also determined by the CTA data set in FFRCT. If you contrast that with patient B, again, a 70% stenosis in LAD. However, this is abnormal by FFRCT, and this patient was confirmed to have this in the cath lab and underwent PCI. So this kind of concomitant testing or add-on testing to coronary CTA can really help us know if a patient has a significant blockage and what we should do with it right now. This is data from the PRECISE trial, which was a large randomized trial of patients evaluated with stable chest pain symptoms. And what it did is it took patients in a precision pathway arm, and these were patients who underwent coronary CTA and add-on FFRCT if needed, and compared it to traditional testing. This could be functional stress testing, ECG stress testing, or direct referral to the cath lab. This was a large global study, several sites, nearly 2,000 participants. And they met their primary endpoint, showing a 70% reduction in the composite of all-cause death, non-fatal MI, or invasive coronary angiograms without obstructive disease. And this was largely led by the fact that patients were found to have disease in the cath lab that was not obstructive. So when you summarize the findings of it, you're going to see fewer false negatives with a CTA FFRCT pathway, fewer false positives, and an overall higher diagnostic yield. You're going to directly identify who needs to go to the cath lab and who doesn't. And I think that's where traditional stress testing has failed us over the past few years. We've just not been able to appropriately determine who needs to go to the cath lab based on functional imaging. This is data from Cone Health, and we've kind of looked at this internally, especially as we've transitioned to CCTA as a primary evaluator for chest pain patients. What you'll see here are revascularization to ICA ratios or cath ratios by year, 2019 through 2023. And the blue bars are coronary CTA, and then patients who ended up in the cath lab without coronary CTA in orange. And then the gray shows the total revascularization rate. And what we saw with the transition to CCTA is that we were identifying patients who needed to be there. They were more likely to get revascularization, much less likely to get it with stress testing or functional imaging. And overall, in our cath lab, we saw a 12% increase in elective revascularization, an overall 1.5 higher yield of revasc if you went to the cath lab with a CCTA first compared with other imaging. And this is real world data, which really shows the impact that CCTA can have on your site and your practice. I think another piece of why coronary CTA is really taken off, we talked about the preventive piece, but where it's really going is the AI coronary plaque analysis. And what we're able to do or what vendors are able to do is they're able to take your coronary CT data sets, and using some AI algorithms, they're able to look at the coronary arteries and determine how much calcified plaque you have objectively, how much non-calcified plaque you have, and how much low attenuation plaque you have. We all know clinically that the calcified plaque tends to be stable and the non-calcified plaque can be unstable, or even the dreaded low attenuation plaque. But what you're able to do in a more high fidelity manner with these tools is determine how much plaque is there, as well as give an objective number to the amount of plaque volume that is present in the coronary tree. This is just a case example that we use at our site from HeartFlow. And basically, this just shows you an LAD. You can see that this patient has mild to moderate disease, likely moderate in the LAD, lumpy, bumpy. There's calcified plaque. There's non-calcified plaque. This was sent for FFR CT, which was negative across that prox LAD. But what you're able to do, and you're able to see in a nice way, is you're able to see the calcified plaque, the non-calcified plaque, and even the low attenuation plaque. I don't have a video here, but you are able to go through it and kind of scroll through and see where the plaque is. And what it does is it gives you an objective number for how much your total plaque volume is. And this comprises calcified plaque and non-calcified plaque and low attenuation plaque. And you're able to get percentiles. And this really has a huge impact from a preventive standpoint. This is data from the DECIDE registry, which has started to look at this AI coronary plaque analysis and what we should do with it. And basically what you'll see with this tree here, or this table, is you're able to stage the plaque, mild, moderate, severe, or extensive, based on the total plaque volume, again, calcified and non-calcified. You're able to see what the lipid biomarker goals are and what the thresholds for treatment are. You're even able to know what to do with the nomograms or the percentile and certain risk enhancers. And I think the nice part about this table is it gives you a nice decision tree on what to do and suggested therapies. This data was published in July by our group and others, and it really just shows you nicely what to do with some of this, especially as we move to a more preventive focus for coronary CTA. And I think that's the nice piece of this as well. When you look at AI plaque analysis, it's a better predictor than calcium scoring alone. Currently we're pursuing coronary CTA for patients who have symptoms, but I suspect in the future we will be doing this in patients without symptoms because it's such a stronger predictor. And this is data from the Lancet, which showed that total plaque volume is a stronger predictor of MI, irrespective of CV risk score, coronary calcium, or stenosis severity. And that really speaks volumes to the preventive aspect that you can get with coronary CTA. So how do you scale up, or how do you start a program? And I always say coronary CTA is not just a scanner, it is a program. These are the key components that I see that are needed. You're going to need a physician champion to oversee that work, trained nurses and technologists. You're going to have a good reader pool of cardiologists and radiologists. I think fellowships have been slow to train in this, but that's rapidly changing. You're going to need nurses. They're going to have to facilitate the scan, give IV medications. These patients do get IV beta blockers or nitroglycerin on the table to control the heart rate. And you're going to need very skilled technologists who know how to do this work and interpret the ECGs. I think some models you'll see with scheduling, you could have a dedicated cardiac scanner like our site does, or you could have a shared model like we used to have. And you really have to be able to optimize the time on the scanner regardless of the model you have. So CCTA is a procedure. It's not just scanning a patient like a CT head or a CT chest. The patients have to have adequate IV access. Their heart rates have to be well controlled. We tend to give pre-medication with beta blockers orally 2 hours before the scan. We want to make sure it's an appropriate heart rhythm to scan. Blood pressure has to be appropriate. These patients do give nitroglycerin. Coronary CTA, FFR CT are all predicated on maximum hyperemia, so you have to make sure the patients do get nitroglycerin. So patients with low blood pressure are not good candidates for the test. And I always say patients have to follow commands. They have to hold their breath. That's even more important when imaging the coronary tree. Our site utilizes a CT nurse navigator. These are dedicated nurses who are able to review orders, make sure patients are appropriately pre-medicated. And it's really allowed us to increase our growth and see tremendous growth in the volumes that we do. And all of these nurses can do all the work that we just talked about. I always say this is kind of the busy slide, kind of the must-have pieces, but this is what you think about whenever you put a program together. You want to think about what's going to happen when I place that order. Is the business plan there? Do I have a good recruitment strategy for patients? Are the patients appropriately selected? Do I have good order sets? And you can streamline all of this at your program to really grow. Even the scheduling can be problematic. Are you sending the right patient to the right scanner? Not all CT scanners can do a coronary CT, so you have to be aware of that. We utilize nurses to do a lot of the nursing review, meaning are the patients on appropriate meds? Are their heart rates controlled? Is the rhythm appropriate? Do they anticipate any difficulties in completing the scan? And another key piece is the technologists, and the nurses are there as well. But the technologists have to recognize certain things, heart rates, arrhythmias. They have to know how to scan the patient. I'll talk later about some solutions for that, but it's just something you have to think about, especially when you want to optimize times on the scanner or increase your slot utilization on your current scanners. And then the physician has to interpret it. You have to make sure billing's there. Are you going to utilize FFRCT? Is there going to be a RAD overread, a radiology overread for your cardiologist? And how are you going to handle the pro fees and maybe a fee for that radiologist providing that overread? So these are things to sort out, kind of a busy slide, but all of the pieces that you would need to think about to scale up and grow your program or even start it. So what's been the barriers to coronary CTA growth? And I think these are just a few that came to mind when preparing these slides. You need to have trained readers. This could be cardiologists or radiologists, but they really have to know what they're doing. And a lot of physicians can get training while on the job or in fellowship. And I think practice patterns are changing with this. You may have an office-based practice with stress testing. I think as reimbursement improves for coronary CTA, which is our next one, I think you're going to see more practices opting for coronary CTA, especially given the preventive information you're able to get from it. I think you're seeing more coverage and less denials for this test. We hardly see any denials in our practice, but these are just things to consider. Bigger things to complete the scan, knowing that it's a program, are workforce shortages. You may have difficulties finding nurses or even skilled technologists. So you absolutely want to be efficient in your day to optimize time on the scanner for slot utilization. I think proper CT equipment can help you. If you choose the right scanner for your institution, you'll be successful. And then lastly, IT support is paramount. We're use these are high volume data sets that go to your PACS. You're going to use advanced visualization software. You're going to use several AI technologies we discussed here, plaque analysis and FFRCT, and you're going to have to be able to incorporate them into your practice. So it's a huge lift to do all this, but it is doable. So just to focus on the scanner selection and what the technologists do, we found this to be paramount with program growth. This is a busy slide, and I do apologize, but these are kind of the workflows that you'll see. You have two types of scanners out in the market. You'll have large volume scanners, which can scan the heart in a single beat or a single acquisition. These are the 16 centimeter detectors. And then you have narrow coverage detectors or smaller slices when you're acquiring that. Just to walk you through the narrow detector coverage for a CCTA patient, it's really important to know what the heart rhythm is. You know, patients with AFib or very irregular heart rhythms really can't be scanned successfully. You have to decide, is the heart rate high or is it low? Are you going to scan diastolic imaging or even systolic imaging? You're going to have to determine body weight and lots of things. Do you want function? You know, you really have to have all your ducks in a row when you're scanning with these smaller detectors. One thing we've utilized and allow us to be very successful is the large volume 16 centimeter detectors. These give you full heart coverage in a single beat, meaning you can scan the heart in a single beat. It really doesn't matter what the heart rhythm is, AFib or not, you can get good high quality imaging. The technologists really don't have to interpret the EKG, which is nice. If you can imagine, it's hard to find very well-trained technologists on coronary CTA, so having them to be able to do it very easily is really nice. And we've really switched to the Revolution or the GE Revolution Apex platform. And just to speak a little bit about the benefits of that platform, there's a lot of automation. The scanner is able to decide where to scan the patient in systole versus diastole, meaning if the heart rate's high, the scanner can automatically decide to scan in systole. There's motion correction with snapshot freeze and also examples of that. But that can really allow you to scan higher heart rates and get motion-free imaging, which is crucial to determine what you're dealing with each case. It's easy for the technologist. I say it's an easy button. That's kind of how I describe it. And with this large volume acquisition, you're really able to do a narrow bead acquisition and really reduce the radiation you're given. We found that we give a quarter less radiation with the large volume scanners than the smaller narrow detected coverage. And we've actually been able to utilize our slot utilization very well. We've actually gone from 30 to 45-minute slots, which I'll talk about a little later, down to 20-minute slots with a single beat wide detector coverage for the coronary CTAs. So I think this is paramount when you're starting a program, growing a program, or even deciding what scanner to select next. I would encourage you to think about some of the large volume scanners. They've been very beneficial for our program. And this is just some cases I'll walk through in the end about how we've been successful. This is a coronary CTA, and again, you want to shoot for very high quality imaging, but this was a patient with atrial fibrillation. Before a year ago, we were not able to reliably detect or reliably pursue coronary CTA in patients with AFib. You know, when you scan the heart in a single beat, you really just need to get the heart rate somewhat controlled and you can get high quality motion-free imaging. But this is one piece to that. When the patient comes to the scanner, our technologists really don't need to look at the rhythm. They just need to know what the rate is and is it acceptable for that scanner. But I think that's just been really nice, a nice addition to our program. You are going to have to image, especially as you grow higher calcium scores. We routinely get asked to do this all the time, but this was on our scanner, single bead acquisition with a patient with a calcium score above 2,000. You can get high quality imaging. We used to limit patients with high calcium score values, but as long as it's reasonable, and I say less than 1,500 or less than 2,000, we'll go ahead and do it. We don't really screen up front unless the patient's already had a calcium score, and that just means if the patient is referred for coronary CTA and we didn't know the calcium score, we would just proceed. We don't stop the scan based on what we find kind of pre-scan with the calcium score. This is just that motion correction or snapshot freeze. And again, this is unique to the GE platform. But what this is going to do, it's going to take, you can see the image on the left, which is the non-motion corrected image, and it's going to correct it, which is the image on the right. And there's some AI behind that, and it's able to do that and give you high quality imaging. And that's been another piece for us to really be efficient with our scans and move faster through our day-to-day. This is just another example of high BMI patients. This is kind of the perfect storm for a possible non-diagnostic scan when I talk about this case. But this was a patient with a BMI of 50 who was in AFib, and their AFib was not well controlled. That's a difficult patient for coronary CTA on smaller detectors. But actually, we were able to scan it, narrow bead acquisition, the scanner detected automatically in systole. The BMI was 50, which is pretty large. We do high injection rates, which is a little bit of a different discussion, but we inject everyone around 7 to 8 cc's per second, and that can really bring out the contrast and reduce that noise when doing that. But for the most part, and just showing you the patient's scout images to prove their BMI was 50, this is someone who likely would have a non-diagnostic scan on any other scanner. But I do think because we were able to do the single bead acquisition, scan at a high injection rate, and use motion-free interval imaging with the snapshot freeze, we were able to get a very high quality, very diagnostic image for this patient. And I think these are patients who routinely are denied coronary CTA, but likely are candidates depending on the appropriate technology. This is some other cases about how you need to be with your throughput. Our structural heart volume has really increased throughout the years, and cardiac CT has become paramount for evaluating this. This is a patient who is undergoing a TAVR evaluation, and with the motion correction, the snapshot freeze, and that large volume scanner, you're able to get motion-free imaging. So I can tell you, not only does this patient have really calcified and severe aortic stenosis, I can see it throughout systole without any motion. This patient was appropriately TAVR, and you can see the nice imaging function that we're able to get, and even a nice look at the mitral valve. And then on the right are just some numbers and some data points we acquire for the TAVR measurements. But there's no motion, very high quality imaging, and this allows for high throughput. This was another patient, and cardiac CT, as it grows and as your site grows, you'll have other indications. You'll step away from coronary CTAs, or you'll add other tests onto it. And this was a patient actually referred for a mitral valve TMVR, transcatheter mitral valve replacement evaluation. But with the large volume acquisition, with motion-free imaging, we're actually able to see that mitral valve. You can see it's severely stenosed. It's not opening well at all, but we're able to get a good look at the prosthetic aortic valve this patient has. And we're able to exclude any issues with that valve. But this patient, again, just to point out, was in AFib. Again, a patient you may not send for cardiac CT that often, but because of the large volume imaging, we're able to get high quality imaging. We're able to get motion-free imaging, which is not offered on most scanners or some of the technology out there. Another nice piece of this was with the motion-free imaging, we were able to exclude any obstructive CAD for this patient. So this patient did not have to go for an invasive angiogram before their procedure. We could plan the whole procedure and get all the data we needed from a single acquisition and a single scan. And I think when you look at throughput and value-based care models, cardiac CT is value-based, but this is a good way, at least our site has been able to reduce diagnostic costs for a lot of these pre-procedural planning cases. And this is another case just showing you how we've kind of expanded. This was a patient who underwent tricuspid evaluation. This patient had significant tricuspid regurgitation. I just want to point out these are all CT images. When I do talk to my MRI colleagues, it does look like an MRI, but that's because of the large volume acquisition, the motion-free interval imaging. I'm able to get an accurate assessment of the RV function, even the LV function. You have a two-chamber of the right heart, you have an inflow-outflow of the right heart, and I've got a short axis at the base. I can measure that regurgitant orifice area very well, and I can plan out a lot of structural heart planning for tricuspid valve with CT. And this case just highlights that quite well, the imaging you can get with the motion-free intervals and just high quality imaging that you're going to get and need to be fast. And I think as your structural heart programs grow, these fancy CT scanners, these high quality scanners are paramount for you to get scans completed very quickly, as well as to read them very quickly. I think it's very easy to read a study that's this high quality, and that was on the Revolution Apex platform. Another feature we found unique to the GE Revolution Apex series has been ECG lists. What does that mean? Whenever we do a coronary CTA or a cardiac CT, we actually have to gate it. So we have to know where the heart's beating based on the cardiac cycle and the ECG signal. And what you can see here is with the platform, you actually don't even need to have ECG leads on the patient. You can actually determine their heart rate based on a pulse ox, give the scanner some information about what the heart rate is. The scanner will scan the patient and then select the motion-free interval. And this was a patient referred for coronary CTA, and really we had trouble with the leads. It just wouldn't work. And sometimes this happens. Sometimes you have to restart the scanner. But we were able to scan the patient without having to restart the scanner, bring the patient back. We just went ECG lists. And you get high quality imaging, diagnostic, and this patient has non-obstructive CAD. So we were able to scan the patient and not turn them away. We didn't have to cut the scanner down, which can impact throughput. This is key for a high quality, high volume program. Here's another piece we've actually started to look at. This was a patient was sent for a TAVR evaluation, and they had a pacemaker. They were being paced, and they were actually having issues gating because of the pacemaker. We switched channels, we troubleshooted on the scanner, but weren't able to do it. So we said, let's just scan an ECG list. So we acquired the acquisition without an ECG lead, the entire cardiac cycle, and we're actually able to go back and process it with motion-free intervals. You can see the tricuspid valve very well. You can see all of the function, and I can size this TAVR valve very well without even having ECG leads. I think this was huge when we were able to shift to this. We're not able to turn away patients who may have been turned away based on the scanner or maybe a breakdown in the leads that you have, but it's just been really key for us for throughput and being as efficient as possible on the scanner. Lastly, I'll just talk about kind of our experience at Cone Health. We have shifted to a dedicated outpatient center, the Cone Health Bell Family Heart and Vascular Center. This is a HOPD site. We actually have an entire imaging suite, a dedicated GE Revolution Apex 16 centimeter system. It was installed earlier this year. With the large volume acquisition, we're able to really move quickly. We're able to set programs up quickly for coronary and structural heart. There's not a lot of training needed. The technologists really like it. Again, they don't have to interpret the ECG. There's not a lot of decisions for them. They're really able to know what scan protocol they're going to do, a large volume acquisition, and move fast. And it's really helped us move fast with acquisition as well as interpretation. Our current model for a cardiology dedicated system, we do all of our cardiacs within 20-minute slots. We're up to 25-minute cardiac CTs a day. We actually do 40 total scans a day on that scanner. We actually do 15 non-cardiacs. These could be CT, chest, aorta, but we theoretically could do up to 40 cardiac CTs a day, and we've increased that volume, but we're a little limited by reader capacity. You can imagine no one wants to read 40 cardiac CTs a day. But I think the key part is we're not limited by the technology, the technologists. We're able to maximize the scanner with our selection and what we have currently. And in addition to those 40, we're doing walk-in calcium scores. And that just speaks to how efficient we've been able to become with that system. Our previous model on a different scanner, narrow bead acquisitions, multi-segment reconstructions. We were doing a full day, but we were only able to do 17 cardiacs a day, and that was it. We were maximized on that scanner. We weren't able to do other non-cardiac structures. As our volume grows, we weren't able to turn up and add on patients who needed cardiac scans. So we've been really pleased with the platform we have and the technology we've implemented. And we really have seen just high heart flow acceptance rate. I think that's the standard on the market these days of how quality is your imaging. And basically we have over 98% acceptance rate to heart flow. And we've been really pleased with the technology we've implemented, the throughput, and how efficient we've been able to become as a system. And I really think these are things that you have to think about when starting a program or growing a program. So just to conclude, cardiac CT is the preferred modality to evaluate most patients with stable chest pain symptoms, assuming they're a candidate for CT. FFRCT and plaque analysis are paramount in evaluating these patients, using the CT data sets in a meaningful way. The key components we discussed for the program, the physicians, the nurses, the technology. No matter what you do, slot utilization is important. And I really think the scanner you select and the technology you incorporate is paramount to make yourself as efficient as possible. And I'd say you must be efficient. The volume is going to only continue to grow, but you really need to have high quality studies as well. And we've been very pleased with the single bead acquisition and the motion correction imaging to really help us with that. And I'll stop there and I'll turn it over to Dr. Sandoval, who's going to talk about CT-guided PCI and some kind of the newer things that are being used in cardiac CT in practice. Thank you.
Dr. O'Neill,
yes.
One quick question for you before we transition to Dr. Sandoval. I think we've had some questions come in during your presentation, and I just want to capture one now. We'll capture the rest at the end. But what the question is about the ownership between radiology and cardiology and acquisition of the scanner and governance and scheduling slots. And did you have to navigate that with radiology, or did you just get approval to say, we're going to do all of this inside the CV service line, create a CV dedicated CT? And what was that process kind of like in whichever way you went, and what is that process like in your health system?
I'll try, Joe. That's a long answer to that question. To answer very shortly, when we started 7 years ago, we started as a shared model. Most CT scanners in a health system are going to be close to ERs or freestanding ERs, urgent centers. And we basically went to them and we wanted shared time. So they basically started giving us a half day. That grew to a full day. Then that grew in radiology to a dedicated scanner. I was a key stakeholder involved in scanner selection, buy-in from the cardiology practice, buy-in from the radiologist for overreads. It was a feat to get going. And then basically as the volume came, and we're doing, I think we're going to do around 5,500 cardiac CTs this year in the system. As the volume came, the radiology administrators and the radiologists themselves were very interested in growing the program. And then that led to more sites opening up. Ultimately, when we had our dedicated building, we decided we needed our own dedicated system in cardiology, and it led to that. But I think most sites, Joe, to answer that, are going to start off with physician champions, shared models. It's going to grow as you bring the patients. And the nice thing about being a cardiologist is we own the patients. We want to bring the patients to the appropriate testing. It's going to grow, and your site may lead to a model like ours. We have lots of sites throughout the system, 6 sites that do cardiac CT that are shared, 1 dedicated site, but it'll grow. But it starts small and it grows big depending on the stakeholders who are involved.
There's so much there that I know we can't get into with the time we have, but it sounds like that could be its own discussion and probably deserves a dinner to go along with it for sure. But thank you very much, Dr. O'Neill, for the presentation. We'll come back on and take some additional Q&A at the end. But right now, I'd like to welcome Dr. Sandoval. And Dr. Sandoval, we will have you take it away from here and take us through your presentation. So thank you for being here.
Thank you, Joe. Can you guys hear me okay?
We can.
Wonderful. Well, again, thank you for the introduction, and what a great kickoff presentation there by Dr. O'Neill. That I think one thing as we transition now to PCI procedural planning, I really want to echo something that he mentioned, which is a program, right? So right now, this latter part of this webinar presentation will be focused now on planning, but I really want to echo what he said, right? I and our team cannot do this whole PCI planning that I'll be showing here over the next minutes unless you have high quality image acquisition. All these protocols are in place. So really everything that I'm going to talk about here for the next 20, 30 minutes relies on really superb image acquisition, good protocols. So really, I am not, in my part of the equation, I am not really thinking about those aspects, because the team that program the cardiac images, radiologists, cardiologists, the nursing technologists, everybody have really focused on good image acquisition that now enables me to interact with the data for PCI planning. So I really want to highlight, I think, that from the program perspective. So for those of you that have not heard this message of CT guided PCI, this is something that I think it's very possible that you might have never ever heard about this. This is something that I think really has taken momentum over the past 2 or 3 years, and I think it's right now at an inflection point that you will likely hear more and more about the role of CT for PCI guidance. This is just a fact of the history of I would say cardiac interventions, right? If PCI had started today, it is highly unlikely that we would have not done it without some PCI, with some guidance like with CT, right? Like right now, as Dr. O'Neill was showing in the structural world with tricuspid, aortic, and all these procedures, imaging is part of what's intrinsic for PCI guidance. It just happens that angioplasty and all those things have started before all these technologies and AI were about. But right now, I think the coronary world is entering this new phase. For those of you that say, I really want to catch up with all the literature, trials, evidence, opinion in this field, I would invite you to look at, there was this multidisciplinary effort involving cardiac imagers, radiologists, interventional cardiologists, and a lot of leaders in the field from both SCAI and SCCT that was co-published in SCAI and in JSCAI as well as in JGCT earlier this year, that really talks about how this rapidly evolving of CT-guided PCI is really shaping. So just adding this here as a resource, this is something that you might want to look into. So what is CT-guided PCI? Again, I think this is a catchy term, but you may say, like, what exactly is this? And I really want to just highlight you here the underlined section, right? This is pretty much shifting us from being, again, I'm an interventional cardiologist at Minneapolis Heart Institute. So this is shifting from us just looking at the PDF paper report from our imagers that says consider a cath or cath recommended, to now saying, I want to interact with those images for PCI planning. And as Dr. O'Neill said, I'm sure we would love to, all the cardiac imagers and radiologists give us a recipe of how to do this procedure. But as he alluded, they're reading 40, 50 procedures, structural, peripheral, and it is just not feasible on a day-to-day practice to expect that there's going to be PCI planning from every artery that has some potential amenable lesion for PCI. So therefore, I think as many of us see this field evolving, it is that the interventional cardiologist will really really need to embrace the desire to interact with this information to help with PCI planning. That's something that either the interventional cardiologist can do alone if they train in how to look at these images, or of course in partnership with the imagers and look at them together. And I would say it's probably a little bit of a hybrid depending on the case. I think as alluded in the prior presentation, and just to go through this should not be some sort of like radical thought and alien idea of like, why are we doing CT for PCI? Because this is what happens in, I would say, in arguably in most procedures out there, right? It happens for left atrial appendage occluders, ablations, TAVRs, tricuspid, mitrals. The question is more, we have not been doing this in coronary artery disease. And the question is, can we incorporate a lot of these lessons, I would say, from the TAVR experience into coronary PCI planning? Now, you would say, well, there's a lot of beautiful images and exciting 3D models that I will show, but is there actually any data to support this, which I think is a fair question. And the reality is that yes, there's an increasing amount of data which is not observational. It is not like single center. This is high level prospective randomized trials that are coming in, I would say also in an exponential, very short period of time. We're seeing more and more trials in this field. Here, I'm just showing 3 trials on the left, prospective randomized trials of CT for CTO PCI that showed improved procedural success, fewer complications. There's not 1, but 2 trials for bypass. And there's also a recent pilot trial in circular interventions for osteolesions. The pivotal P4 trial, which I will allude to, recently completed enrollment earlier this year, and we're expecting the results a year from now. And there's at least a few other trials in the pipeline. So this is a field that I would say there's very high level quality data showing that incorporating CT for pre-procedural planning is something that, as shown here, can help likely with procedural success, improving procedural efficiency and outcomes. Now, I just mentioned the P4 trial. I think this has been a very important accelerator of this field because, of course, we're not just looking to add images and, let's say, extra work without an outcome, a measure that we're improving. And, of course, this is now the first, I would say, pivotal trial in this field that is randomized into what many of us would consider the standard of care to doing intravascular imaging-guided, IVUS-guided PCI against CT-guided PCI with a primary endpoint of MACE at 1 year. As I alluded, this is just like about 1,100 patients that were enrolled just earlier this year. We're all expecting to learn the results of this probably a year from now. And this will be, I would say, a very important trial that if it meets their primary endpoint, will have an inflection point of really accelerating the field of incorporating CT for PCI planning. Now, pending that trial, many of us have taken the initiative to incorporate CT into our practice. And why is that? Well, it's because I think it's really hard to ignore that there's increasingly facile softwares and technologies that can really be brought to the cath lab to facilitate PCI planning. Our journey for doing this in the cath lab started in April of 2023 when we started using the PCI planner, virtual planner, using the FFRCT platform. And I think it's an important metric going back to Dr. O'Neill. He really talked about this from a diagnostic perspective as the gatekeeper of the cath lab. But now, as you can see, in patients that come to the cath lab with the CT, now we can use this information not only for diagnostic purposes, but now for procedural guidance, in which we can virtually implant stents, understand what is the optimal stent length. We can also understand what would be the optimal post-PCI FFRCT predicted. And you can see now how there's a shift in CT being a tool just from a diagnostic purposes now to PCI planning in the coronary field. And as you can see here, we're now about to enter our 3rd year with this experience, which has been really growing, but just allude to that. This has been a journey talking about this issue of programs and elements. Our journey, and everybody has a different journey. Our journey started with physiology and virtual PCI planning, but has lately been increasingly have now a portfolio of elements that we care about. We care about the 3D models just to get a case overview of what's happening in there. This is something that our imager, radiologists, cardiac imagers would usually not look at, but for the untrained, interventional cardiologist that wants a quick understanding of what's happening, you can show them a 3D model like this and say, yep, I understand there's some calcium disease, bifurcation, diagonal. I probably need 2 wires, one from the LAD, and I want to protect that that side branch. So an MIP, a 3D ball and render image, is a very easy way to display and convey that information to our peers and colleagues about what we're about to encounter. We can use this for guide selection, so we can therefore have a more personal approach to the procedure. We can understand disease length, we can understand vessel size, and there's, I would say, increasing amount of interest in using, Dr. O'Neill alluded of plaque for prevention and rectification, but now incorporating plaque for procedural planning, because now there's very, I would say, facile ways to look pretty much in your laptop, cloud-based systems, to look at pretty much at plaque, and in a very easy way, like here, understand, look, this is circumferential calcium. This is not something that you want to direct stent or something that you just want to do plain angioplasty and stented. This is something that you may want to think advanced calcium modification, and you can show here on the right, you can pretty much come up with a plan of, like, here, it's an LED diagonal bifurcation. I need 2 wires. They should not be done at the ASC. They should be done at the primary site that is equipped to deal with calcification, with bifurcations, with complex cases, with an operator that is, expert enough to deal with this. You can see the RCA has an anterior takeoff, so you need probably an AL1 catheter, and you pretty much, I would say, we enter this new phase in which we're no longer winging it in the cath lab, but we are no surprises. This is what we're getting into, and this is the new phase that we have. This is the group that I said came from Sky and SSCT together earlier this year to discuss these issues. And again, for the imagers in the audience, this is something that are very basic elements, but as we enter this new field, I think we want to educate everybody's part of this team and program on what is the language, right? So this is what our document, our consensus identified, our terminology that we want to make sure that we're able to communicate across the specialties, right, between the interventional cardiologist, surgeon, imager, and talk about, what's the MIP, axial images, multiplanar reformation, short accurate cross sections, CT-based physiology, myocardial mass, and CT co-registration. So these are things that I think we're going to hear more and more, and we want to be able to communicate. Now, you would say, well, the randomized trial, the pivotal, hasn't been published yet. Why should I do this now? Well, the reason our healthcare system incorporated this, we're a large healthcare system, the largest here in the Twin Cities, with a lot of heterogeneity. We have an ASC, a primary hospital at Abbott, another one in St. Paul, etc. Is because it became very apparent that if we shifted using CT just for diagnostic purposes, but for procedural planning, that this was a great triage tool. So as you can see, the case on the left, it's a focal non-calcified mid-RCA lesion. This is pretty much as a type A lesion as we will ever encounter in our practice. This is something that can be done in any cath lab within our healthcare environment by any operator at any time. Whereas the case on the right, you can see, is diffuse calcification all the way close to the left main, diffuse disease. This is something that I don't think requires a level 3 highly trained cardiac CT readers. You just show this to any interventional cardiologist and they would say, I want this to be done at 8 a.m. at my primary site, well equipped and well caffeinated to deal with a complex lesion that has a lot of calcium, and I may have to do some advanced calcium modification for this. So you can see just from looking at one image, yes, we all await these randomized trials and data, but just by looking at this, you can see the power that this will have probably for procedural planning. Now, those concepts that I'm talking about, there's the MIP on the left, focal mid RCA non-calcified, on the right, severe diffuse calcification. In one image, you can really get a lot of information just to triage. This is nothing for diagnosis, and the imagers will keep us honest that we don't want to put a lot of weight in this sort of MIPs for saying is there something severe or not. But for the interventional cardiologist that just wants to get a quick understanding, is this complex or not complex, showing this image has a lot of power. Axial images, of course, this is unavailable in any PACS X-ray system, but a visualization software, but it's valuable because just by looking at an actual image, we know whether the RCA is coming around 11 o'clock, which is the normal takeoff of the RCA, and if not, like in the other example that I showed, was coming more anterior around noon, therefore we can use an AL1 guide, and likewise for the left system, we can get an understanding of what is the takeoff of that left coronary artery, but also the distance, and therefore we can inform what guide catheter shape size we want, whether we want a 3.5, a 4.0. Here you see this is 4.8 centimeters, so therefore you want probably at least a 4.5 or 5 guide. So by using and interacting with this information, you're making your procedure more efficient. Here's one example of that. The RCA is coming almost 1 o'clock, very anterior. You can see this in the angiogram. So therefore, I don't need to go and fumble around and use like 3-4 catheters and increase radiation, increase contrast. I can just say, I saw the CT. It has a very anterior takeoff. I therefore need an AL1 guide, and therefore that's going to reduce instrumentation, radiation, and contrast use. And this is what we're learning more and more. This procedures has a lot of value. Now, of course, there's a lot of softwares that I will show that are really pushing how we interact with this data, but I think it's important to also take a step back. And the reality is that CT-guided PCI can be enabled with a standard post-processing visualization software. This is one of those examples in which you can really create a CT-based MLD in which you can say, what are your landing zones? What is the vessel size in those landing zones? What is the length? Is there some calcium or not? How does LACO look in the model, and what's over those angulations? So you can deploy a CT-guided PCI algorithm with a standard post-processing software. Arguably, the issue with this is that this is sometimes harder to click and interact with, but there are ways to do that. And as you can see, this is very straightforward, as you can see here, because you can get the length and the understanding of plaque morphology, calcium. So it really gives you a lot of information for those of you that are interventional cardiologists that mirrors what we do in the cath lab when we do an OCT or IVUS pullback, very analogous to that. You can do now pretty much an MPR CT pullback to understand what are the characteristics of that plaque and morphology and plan your case accordingly. Now, calcium, I think it's a very important story of this. Why? Because calcium, not long ago, probably many of you said like, oh, the CT has a lot of calcium. The calcium has very high calcium score. We should not therefore, this is non-diagnostic, or we should not do the CT. It has a high calcium score. This has, I would say, drastically changed for sure in our practice, where we actually want to know whether that's the case, whether there's a lot of calcium, because as shown here, therefore we know that there is very high ARC, very significant concentric calcium, and just this piece of information transforms how we, from a procedural aspect, encounter these procedures. And because we know that once there's severe calcification, this is very complex. This is rapidly changing. Dr. O'Neill showed this again from the plaque prevention perspective. Now, from a procedural aspect, now as shown here, and now pretty much information that is provided to you in a very facile manner, as shown here, you can see MPRs, cross sections and 3D models that show you that arc of calcium very easily, and therefore you can understand. And again, I would say it democratizes the ability for others, particularly proceduralists, to look at this information and say, yep, look at that. There's a pretty good arc there. Should I be thinking about specialty balloon, scoring, cutting, intravascular lithotripsy, atherectomy? And this is information that is increasingly being democratized to be used by, evaluated by other users in the cath lab and whatnot. Now, this is rapidly evolving. This is investigational, but be aware that this is what was tested in the P4 randomized trial. This is now 3D models that look at 3D models of plaque and calcium. So again, this is a very rapidly evolving field, and it's creating new concepts like calcium distribution. It's something that we had usually not thought about, but now we can understand how is that calcium distributed across the vessel. Is that something that is, helical shape? Is posterior? Is it coming contralateral to the diagonal? So calcium distribution is an important concept. We've discussed a little bit about physiology. My one message of physiology is that we want to shift in a binary normal, abnormal FFRCT to being comprehensive about this. What do I mean about this? When we come to the cath lab, we would usually think about bringing the wire distally, doing a pullback and phenotyping the coronary artery disease. You can do this with CT2. These two cases arguably have the same abnormal FFRCT and have the same distal FFRCT value. Yes, of course, on the right, this is distal, and you could argue this is just some vessel tapering, but technically speaking, both cases have severe coronary artery disease with disease that has similar distal FFRCT values. But if you look at it, by interacting with the information, by doing a virtual FFRCT pullback, you characterize that this is totally different cases. The one on the left, it's focal proximal LAD, significant delta. This is something that will likely benefit from PCI and revascularization, whereas the case on the right is likely diffuse disease, and it's something that will be more best served by medical therapy. You can only unlock this if you interact with the data and click along this rather than with a still 1-point FFRCT. Now, I've talked about planning for virtual PCI. This is something that our practice has been doing now, entering its third year, starting next April. And as you can see, you can do now virtual stents and pretty much understand what is your optimal stent lift based on predicted post-PCI FFRCTs. You can do bifurcation techniques and whatnot. I've talked about CTO, CT for CTO. It's something that I would say it's one of the lowest hanging fruits. Why? Because there's a trial. There's a CTO trial that shows that if we use CT in these very complex procedures, we're going to improve procedural success and reduce complications. And what we're seeing is that you can shift from the traditional approach of looking at CT and slice thickening and double oblique views to now these newer applications that are bringing that AI and novel softwares are bringing. This is with AI QCT, showing you can pretty much have automated detection of CTOs, which you can recreate in a 3D model. And again, we've published now a few papers looking at this, but we're entering again this new era in which is easier to look at this information for everybody in the team. Now, now coming to the cath lab is that this is shifting from just not pre-procedural planning, but be aware that there are now ways to now integrate this information CT in the cath lab. This is on the left what we did in the P4 trial with CM registration, but this is available clinically. This is with the Alia system with GE, which as you can see here on the right, allows you pretty much to rotate the arm and see how the CT and 3D models moves as you move the arm, and that is helpful because you can get the optimal views, reduce contrast, and get reduced foreshortening. Now, you did your whole procedure, pre-procedural planning, you do your stent. What we're seeing now is that there's this emerging opportunities to now align and potentially create CT-based planning, followed by the use of cone beam computed CT, pretty much from your standard CR to recreate a three-dimensional reconstruction of the stent. This is now what one would call the 3D stent. And there are emerging opportunities that you can bring again your entire procedural planning. And then after your procedure, if you have the 3D stent technology from GE, now you can recreate pretty much a 3D stent as shown here to now pretty much align in harmony, doing an entire PCI assessment. This is something that is being evaluated in trials and has been now deployed clinically. And as you can see here, will give you a very nice understanding whether there is calcification, is there stent of their expansion, and and right now I would say the main question that it's out there is this a nice metric as shown here in this video of a stent expansion, potentially facilitating and enabling the understanding of the post-PCI stent expansion in another facile manner, just using your standard X-ray system. Now, to wrap up here, as we're coming out of time, I will show here that this is how this is evolving. This is evolving, and now there's, and this is now something that was launched at TCT, that there is now platforms that will allow us to do PCI planning, I would say in a very facile manner. This is a new technology called the PCI Navigator, which gives you 3D models, but not just for physiology, but for plaque and calcium. It will show you myocardial mass, will give us an understanding of distal proximal length vessel zones, will give a pullback of the physiology. And as you can see here, we will be able to interact with this now for PCI planning in a very facile manner in platforms that are purpose-built for this purposes. So a very interesting area, I would say, in interventional planning and CT from a tool that we had largely thought as a diagnostic tool. We're clearly at the early part of the curve, early adopters, but I think we're going to enter this new area of clinical trials, implementation science, cost effectiveness, and I think this is something that we'll learn more and more over the next 5 to 10 years. I think there's a lot of things that are in this document from Sky and SSCT that we collaborated with that I would say are barriers and opportunities from, what's the optimal hardware, as Dr. O'Neill alluded to, how to integrate the software, what's the unneeded evidence. Education is something very important. I teach a lot about these things, and people are like very interested in slide and approach, but how do I do this? And people want to learn what is the buttonology and how to click to get this information and apply it in a consistent manner and whatnot. Evidence is a big one. As I said, the trial P4 recently finished enrollment, and hopefully we'll learn the results. Education and collaboration is key. Here, we all continue to learn. Just from Dr. O'Neill's presentation, I took a couple of notes because we learned. The imagers are learning from interventionalists and vice versa. We're all learning from each other about what's this information for PCI planning. And to wrap up, I will say that we're just shifting. We're shifting from this, the past, in that we would just rely on looking at a PDF, EPIC report to make our clinical decisions, to now we are really entering this area in which we want to interact this data to unlock this concept of CT-guided PCI to improve procedural planning. And with that, I'll wrap it up. Thank you so much.
Dr. Sandoval, thank you so much. I would like you and Dr. O'Neill to stay on the line and ask a couple of questions, but I also want to recognize that we are at time, and it is now 2 o'clock Eastern. So for those of you that have attended and need to get to your next meeting, we're very grateful. But I would like, because this will be recorded and people can, log back in and hear some of these questions, I have just a couple I would like to ask while we're all here together. And the first one I have is, as we take a look at what you've presented, Dr. Sandoval, I'm curious, I'm always wondering to the extent to which CT-guided PCI is actually being used as a percentage of cases or shaping your treatment decision in what percent of cases. So kind of how is that affecting your course of treatment? How often and to what severity?
In our practice, I'll speak for myself. In our practice here in Minneapolis, I would say this has markedly changed how we make decisions about every case. I would just go to the lowest, concept. It's triage. As I said, like we have a heterogeneous healthcare system. We have a typical mothership that has all the tools, bells, and whistles. We have an ASC. We have a non-surgical backup lab. It takes one CT and looking at that information for me to understand where should this case be done. Is this a case that needs to be done Monday at 8 a.m. or is this a case that it's straightforward type, simple lesion, we can have it done at the ASC. So it's a great triage tool, and therefore I would say this impacts probably every case we do.
Thank you for that. I've got a question for both of you, and then we can maybe wrap here. But what I'm wondering about here is, and then there's maybe one more, but the key aspects of the current technology that you have, and you talked about their staffing, you talked about workflow, but what aspects of the technology are really critical for your program to be successful? What pieces do you need to put together to achieve the outcomes for patients that you're looking for?
Yeah, Joe. So I think you're going to have, when you look at who's doing coronary CTA, you're going to see these higher end fancy scanners, and you're really going to have to discuss with administration and your other, champions within the service line or the health system, and they're really going to have to invest in it. But I think it's key, it's paramount. You can't really do this with some of the older CT systems out there. Not every CT system is capable to give you the high quality imaging you need. So I think you're just going to have to, discuss with vendors what works well for your system. I think anything that incorporates a lot of automated decision trees is really important for technologists. So I think, just having a CT scanner may not be enough. You're going to need to have those tools that can really help facilitate a scan in an easy way, because technologists can leave. The workforce is changing. There's not enough of anything out there, it seems, these days. So I think you just have to be as efficient as possible. So I think key high-end scanners that have the equipment and tools that help you do the work efficiently and quickly.
Thank you, Dr. O'Neill. Dr. Sandoval?
No, I would agree. And I guess my message would be that, this message, at least from the interventional community perspective side of this, is that I think we are learning more and more from the interventional side of things of many opportunities to integrate imaging and CT for PCI planning, but we are not really involved in everything that Dr. O'Neill addressed, from protocols, image acquisitions. So this is where one really needs to partner with that imaging champion that he alluded to and really create that partnership, right? Because you're like, I want to use CT for structural or coronary or peripheral planning, and this is where you need to identify that partner and have that collaboration that Dr. Neal has. We have it here in Minneapolis to really advance, which I think it's instrumental to understand what is the right technology and softwares that will enable really a successful program.
Got it. Well, thanks to you both for that. I have one more. I promise this will be the final one at this point. And it is actually less on the equipment, more on the software, if you will, talking about FFRCT. So the question is, are you using FFRCT on all patients, or, is there reimbursement concerns? How are you deciding who gets FFRCT and not? What does that selection process look like? I'd like both of you to maybe comment on that, and then we'll close out the webinar.
Yeah, we have guidelines on that. There's a 2A recommendation for stenoses in the 40 to 90% range in proximate locations on the CT. FFRCT is used to guide decisions around revascularization. Our site has seen very little in terms of denials. We might get one a year, which is off. And We order, in our practice, around 30 to 35% of scans are sent for FFRCT. So these are patients who need to know what to do with here or now. But for the most part, denials are few and far between these days in contemporary practice.
Excellent. Thank you. Dr. Sandoval?
Yeah, of course, this is like anything in practice, there is some variation, across readers and interventions. But I will say that we're entering a new phase. We even in the cath lab, some of us in the cath lab have the ability to trigger FFRCT, even if it hasn't been done previously for diagnostic performance. So now we are triggering and say, like, I need physiology in this case to support my planning in the PCI. The patient is already in the cath lab, so this is not as a gatekeeper from then coming to the cath lab. We're triggering because it's going to enable and facilitate our decision making in the cath lab, and critically, it is going to therefore unlock this portfolio of applications that we can use for PCI planning. So an important thing is that I think there's a shift in which getting this information will allow the ability to really engage with these tools for PCI planning. And just as a whole, outside of CT, I think physiology is seeing a transformation in which now they are used for physiology from angiograms, from CT. Even the wires and the softwares are having iterative changes in how we interact with this information, which I think there's really a shift from this yes, no, abnormal, normal, to looking at the pullback, what's the post-PCI prediction, FFR, and whatnot. So really, I think the guidelines right now remain, just use it in the intermediate lesions to see whether you're going to treat or not. But I think we're at an inflection point where if we do physiology, even in lesions that are severe, it really engages other information like that post-PCI, FFRCT, planner, other prediction tools that I think we will see more and more moving forward.
Thank you. Well, thanks to you both, Dr. O'Neill, Dr. Sandoval. Appreciate you sharing your expertise. Thanks for sticking around for a couple more minutes to answer some questions for our audience. We appreciate that. And thanks again to GE for helping us to put together this webinar. We're very grateful. And with that, we will end today's webinar. And we will see you all on the next one soon. Thanks and have a great day.